Okay, let's continue with our discussion of the bipolar and related disorders. So, in terms of lifetime prevalence, it's estimated to be between 1 to 7%. Several risk genes for bipolar disorders have been identified, and overall, the heritability of bipolar disorders ranges from 73 to 93%. So family history is something that you definitely need to be asking patients about when they're in for psychiatric evaluations. Environmental, cognitive, and developmental factors also affect the course and the expression of the bipolar disorder. So again, it's a mix of nature and nurture. The public health impact of bipolar disorders is profound. The rates of relapse and disability remain high despite when patients have good treatment adherence. Now, treatment adherence is a problem for a lot of people, especially earlier in their illness. Many patients do return to a fully functional level between episodes. However, about 30% show severe impairment in work role function, even when their episodes go back to normal. Functional recovery lags substantially behind recovery from symptoms. So what that means is, when someone is symptomatic during an acute depressive episode or an acute manic episode, they might do things like drop out of school, or they might be let go from work. Even when symptoms get better, getting people to their baseline functioning takes a lot longer to get them back to the status that they were at before. So this in turn really leads to this patient population having a lower socioeconomic status despite having equivalent levels of education when compared to the general population. Although you might think that the different mood episodes that we learned about are easily distinguishable from one another, in actual clinical practice, it's very difficult to make an early and accurate diagnosis of bipolar disorder. We don't have any biomarkers with sufficient diagnostic validity that we can use in clinical practice. The time lag for a correct diagnosis of bipolar disorder is actually more than 10 years after the onset of first symptoms. So that's about 10 years that someone is not getting the correct treatment and is suffering. Now, we wish that bipolar 1 disorder presented with a manic episode early on in life, because then we would know that this person has a bipolar disorder and we would know how to treat them. However, the way that bipolar 1 actually presents is that people have multiple depressive episodes where they're not getting the right treatment until finally later on in life, maybe they have a manic episode and we realize they have a bipolar 1 diagnosis instead of a major depressive disorder diagnosis, as was thought before. About 3/4 of patients with bipolar disorder were misdiagnosed on initial presentation. This is because most patients seek treatment during the phase of bipolar depression, not necessarily during a hypomanic episode or a manic episode. When the diagnosis is missed, patients are incorrectly classified as having unipolar depression, and other commonly misdiagnosed disorders are anxiety disorders, schizophrenia, and personality disorders. Patients with other disorders like borderline personality disorder, PTSD, impulse control disorders are also often misdiagnosed as having bipolar disorder as well. So here are some red flags that someone who is presenting with a major depressive episode might actually have a diagnosis of bipolar disorder rather than a major depressive disorder. Typically, in bipolar depression, people tend to have an earlier age of onset of their first mood episode. So remember, in bipolar disorder, people tend to have their first mood episode in their late teens, whereas in major depressive disorder, it's in their 20s. Episodes are more frequent and shorter in duration than what we see in major depressive disorder. The episodes tend to be more likely to be associated with psychotic features in bipolar depression rather than major depressive disorder. The depressive episodes in bipolar disorder also tend to have more varying presentations. So, for example, someone might present with an atypical depression for their first episode, and then their next episode might be a depression with anxious features, and then the third episode might be a melancholic depression. We're more likely to see that change in what depression looks like for a person in a bipolar disorder. In major depressive disorder, the depressive episodes tend to be more similar time after time. A really big clue that someone might have a bipolar disorder is if they have a family history. This is the most common and consistent risk factor. A screening tool that can be used in primary care settings to screen for a manic or a hypomanic episode is the MDQ, the Mood Disorder Questionnaire. This questionnaire correctly identifies about 7 out of 10 patients with bipolar disorder and then correctly screens out 9 out of 10 patients who don't have bipolar disorder. About 50 to 70% of patients with bipolar disorder have psychiatric comorbidities. The presence of comorbidities is associated with worse longitudinal course, more frequent mood disorders, more suicide attempts, worse quality of life, and then more impairment in function. The most common comorbidities are the anxiety disorders and the substance use disorders. Sometimes individuals might use the substances as a way of escaping their symptoms. However, sometimes the substances and drugs may actually trigger depressed or manic episodes. People who have bipolar disorder have a lifespan that's 8 to 20 years shorter than the general population, and some of this risk is attributed to suicide, but not all. People with bipolar disorder have higher rates of comorbid obesity, cardiovascular disease, metabolic disease, and they're more likely to smoke as well. Many effective medications also for bipolar disorder have been associated with weight gain and adverse effects on glycemic and lipid profiles. So this is something that maybe contributes to the decreased lifespan as well. Now let's move on to cyclothymic disorder. In cyclothymic disorder, you see ongoing mood symptoms for 2 or more years. In cyclothymic disorder, people have periods of hypomanic symptoms that don't meet criteria for a hypomanic episode, and then depressive symptoms that don't ever meet criteria for a major depressive episode. If criteria for one of these episodes is ever met, then they cannot be diagnosed with cyclothymic disorder. Active mood symptoms in cyclothymic disorder must be present for at least half of the time during the 2 years, and symptom-free periods cannot last more than 2 months at a time in this diagnosis. Now, the cause of distress or impairment in functioning in cyclothymic disorder isn't necessarily having elevated mood symptoms or having slightly lower mood symptoms. The impairment really comes as a result of the prolonged periods of cyclical change in mood. So these patients have unpredictable mood changes, and that change, that switch, is what really causes the impairment in functioning or the distress. Cyclothymia tends to be chronic and lifelong, and about 15 to 50% of people with cyclothymic disorder go on to have a diagnosis of a bipolar 1 or a bipolar 2 disorder later on in life. Now, what is on the differential diagnosis for bipolar-like symptoms? Some substances or medications that can induce manic, hypomanic, or mixed episodes are stimulants, PCP, bath salts, steroids, and antidepressants. Some medical conditions that can cause symptoms that look like manic, hypomanic, or mixed episodes are Cushing's, stroke, traumatic brain injury, and multiple sclerosis. Here are some clues to the presence of a secondary cause of mania, hypomania, depression, or mixed symptoms. If someone presents over the age of 40 with their first onset of mood symptoms, that might be a clue that there's something else going on that's causing the mood, especially if there's no stressors going on in that person's life. If they have unusual symptoms that don't quite match with the diagnostic criteria, that is also another clue to take a step back and see what else could be going on. If they have rapid onset of symptoms or cognitive impairment or fluctuations in sensorium, if they have abnormal vital signs, if they have a known general medical problem or known use of a substance that can cause mood disturbance, that might be the cause of their current symptoms. If they have an abnormal neurological examination, if there's an absence of any personal or family history of psychiatric disorders, that's a clue. And then also if they have an unusual or absent response to established treatments, that's another time to take a step back and see, is there anything else that we're missing about this person's diagnosis or cause of symptoms. So moving on to treatment. Treatment of bipolar disorder depends on the phase of illness. Each phase is associated with specific treatment needs. So in the acute phase, which can be an acute mania or an acute depression, really the goal is focused on management of the acute mood and for crisis stabilization. Sometimes patients may present with severe agitation, violent behaviors, or psychosis during the acute phase, and treatment of agitation may include antipsychotic medications or benzodiazepines. Patients may require hospitalization during the acute phase, including for safety to prevent suicidal actions. ECT could be considered for refractory bipolar depression or be first line for treatment in high-risk situations. The other phase of illness is the maintenance phase. Treatment in the maintenance phase is really focused on preventing recurrence of acute episodes, and in the maintenance phase you can use both medications and psychotherapy. I included this chart just to really show you that the FDA-approved medications for bipolar disorder are based on the phase of illness. So there are different FDA-approved medications approved for bipolar depression, approved for acute bipolar mania, and then approved for bipolar maintenance. And you would pick which medications you're going to use depending on the acute phase that the person is in at the time. Psychotherapy during the maintenance phase helps to reduce the rate of remission by 50% or more compared to other usual care. And this type of psychotherapy can be supportive, can be helping the patient accept their diagnosis, psychoeducation, so teaching the patient more about what it means to have a bipolar illness and its management, helping the patient be adherent to medications, helping them to manage interpersonal stressors, and then also teaching them how to recognize their own red flags for when their mood might be switching, and then being able to respond early to signs of mood switching. Cognitive behavioral therapy can be helpful, as well as group psychoeducation, family-focused therapy, interpersonal social rhythm therapy can be helpful as well. And this is really a therapy that focuses on patients keeping a routine, going to sleep the same time every night, eating meals the same time of day, things like that. And this is important because we know that disturbances in at least sleep-wake cycle routine can trigger bipolar episodes. Many patients also benefit from additional services such as case management or care coordination services. In conclusion, the bipolar disorders can be potentially disabling and life-threatening. The bipolar disorders present many challenges to busy clinicians, beginning with accurate diagnosis. Adequate management requires pharmacology and psychosocial interventions that are targeted to the specific phase of bipolar illness. Mood symptoms and functioning must be continually reevaluated, with treatments readjusted as needed over time.